would like to introduce from orthopedic surgery, we have our second speaker, Dr. Han Ling, who is our trauma and orthopedic surgeons, subspecializing in foot and ankle surgery. So he's graduated from Manipal Universities and then did his master's in University Malaya, graduated in 2021 and joined the departments in 2022. So today his topic is about ankle sprain. I'm pretty sure most of you, or maybe almost everyone, must have had some incidents with ankle sprain. So we see what he's going to share about the topic in ankle sprain.
Okay, thank you. Thanks, Professor, for the kind introduction. So, good morning, everyone. So I'm here today to give us a bit of insight and give you a slight information regarding the ankle sprain and also the hidden dangers of ignoring a common injury. So I'm Han Ling. I'm a medical lecturer and a clinical specialist with foot and ankle unit. So let's start for very simple. I'll just briefly talk about the anatomy of the ankle joint. So the ankle joint consists of three main joints. The so-called the talocrural joint, which is the ankle joint improper, which is as you can see in the red dotted line over here, and subsequently with the subtalar joint. Lastly is what we so-called the inferior tibial fibular joint, which is the joint that is formed between the fibula as well as the tibia. So as you can see, our ankle joint is a quite special joint where there is a high congruent type of hinge type joint. It's formed in the combination of different or various bone and ligamentous structure. And this joint is surrounded by multiple joints, as you can see on the side here. The joint is mainly formed by multiple joints that is surrounding a small joints which is on the adjacent to this area. The movement, and without us knowing, actually our foot and ankle joints are moving in a very well coordinated manner to give us the unrestricted movement for our daily living. So for example, as you can see the image down here, there is the different axis that is rotating around the ankle joint. We have first axis in the abduction, adduction, indeflection, extension, and lastly the inversion and eversion. So when there's so much of movement with so much of joint are limited in such a way and in an arrangement in such a way, there's a very limited abnormal movement that's allowed in each of the joint. So the joints are actually quite forgiving. Any abnormal joint in any part of the little joint could lead to either a bone, cartilage, or ligament injury. So I just go through a very simple, very brief on the epidemiology. So the ankle sprain is the most common or most frequent ankle injury that's been reported. And 80% of the ankle sprain are what we so-call the lateral ankle sprain, which I'll show you in detail later on. And of all the lateral ankle sprain, 30% of patients would go into what we so-call the chronic instability and pain. So what is the chronic instability? The patient would feel the ankle seems to feel like going into the inversion or will go into the sprain again when the person walk on uneven ground, such as grass or sand or uneven pavement. And also sometimes they will have repeated ankle sprain, for example, up to 2 times, up to 3 times, or even up to 5 times of ankle sprain per year. So the risk factors mean for the sports are, for example, the indoor court sports such as badminton, basketball, netball, and even futsal. And individual basically are the ones who some may have so-called balance deficiency and also decreased proprioception. This is a bit difficult to measure, but simply put, usually are for a normal office worker suddenly in one fine day decided to go for a competitive sports without any training. So all these proprioception and balance deficient, all this balance failing, it comes in a progressive manner and it requires certain amount of training in order to get those feelings back. So as we mentioned, the ankle sprain can be widely divided into 3 types. The inversion type, as you can see on the left-hand side. Then we have the opposite, the eversion type, and the high ankle sprain. So The inversion type constitutes to almost 80% of all ankle sprain, and the rest, roughly around 10% in the high ankle sprain, and roughly around 10 to 11% in the eversion type. So as you can see here, just some example of how ankle sprain that actually happened. So as you can see, sometimes it was just the person running forward, then a sudden block on the foot, but the momentum of the body and the leg just keep on going forward and then push the ankle into eversion. And then as you can see here, a poor tennis player where sustained a inversion type of ankle sprain in one foot and eversion type of sprain in the other. So now we will think, does it really happen mainly in athletes? Actually, no. It happens in our daily activity as well. Simply just walk on an uneven pavement, getting up or down the stairs could even happen. So whenever the ankle goes into an inversion, what happens is, as you can see here, these three ligaments are at risk mainly. The first is the ATFL, second is the CFL, and the lastly PTFL. So later I'll show you guys what they all stands for. So another model here, you can see whenever there's an ankle injury, the ankle will go into what we will go into the tilt. Whenever it goes to a tilt, you will start stretching on the outer aspect of the ankle, which is shown here. So the first injury would happen is the one that's drawn in the red circle here. So this is what we call the ATFL, followed by the one that's beneath, which is a CFL. But last but not least, not forget, whenever the ankle goes into a tilt where it is supposedly designed not to, the inner aspect of the what we call the talus, it will hinge on the tibial platform and then lead to either a fracture or what we call the osteochondral defect, means injury to the cartilage. So coming to the symptoms, whenever there's an ankle sprain, depending on the severity, it will be either a simple mild bruising or ecchymosis at the outer aspect of the foot and ankle area. And the severe form, as you can see here, is a big bruising on the lateral part of the ankle and the foot region. So for the initial management without any scan or without any x-ray, to begin with, it's better to first avoid the weight bearing first, followed by rest, ice therapy, compression, and elevation. So why does all this matter? Because whenever there's an ankle sprain, these are all the injuries that could happen to us. One is the bony injuries, and what I mean is the fractures. Ligamentous injury, for example, are the ligaments that I've shown before. So the ATFL stands for anterior talofibular ligament, CFL, the calcaneofibular ligament, and lastly, the PTFL, the posterior talofibular ligament. Of three, the posterior talofibular ligament is the strongest. It's the least common to get injured compared to the first two. And last but not least, the cartilage injury, the osteochondral defect, which I'll show in an example later on. So let's come to a simple management with depending on the severity of it. So when it is just a mild ankle injury or ankle sprain, usually coincide with the low-grade ligamentous sprain, a conservative management would suffice. The management include police. So what's a police? Protected, optimal loading, ice therapy, compression, and elevation. The protected optimal loading basically means the ankle needs to be in some form of support in terms of ankle brace or ankle stirrup. Next, moderate. So the moderate types are the ones that is confirmed there is some form of ligamentous injury in the patient, especially in patients who are active and patients keen to go back to active competitive sports. In those patients, when there's a ligament injury and instability, the patient will require to go through the arthroscopic debridement and ATFL ligament reconstruction. And when there is a osteochondral defect or osteochondral lesion, the cartilage need to go for resurfacing and also autologous matrix-induced chondrogenesis, short form for MIC. And lastly, the severe form is the one that has fractures. Depending on the fracture, whether it is undisplaced or displaced, if the undisplaced, patient can just go for a conservative management with casting. If the one that is displaced, surgical reduction and internal fixation would require. So after this, I will just present a few examples of the cases of in different severity. This is the worst fracture. So this is the first case. A 55-year-old lady, she twisted her ankle while stepping off the pavement. Subsequently, she unable to weight bear on the distal left ankle or left lower limb. Otherwise, the distal neurovascular status are intact. So for this patient, we decided to go for distal tibia nailing and also plating of the lateral malleolus. So this, if I recall correctly, this patient would be the first or second case underwent such a fixation, was the first or second case to be done in Malaysia. The benefit of such a fixation would be a smaller wound. So this fixation patient would just require a 2 centimeter wound with a 2 to 3 small 1 centimeter of stab wound over the leg region or shin area. Compared to a traditional fixation, the patient would require a long plate over the shin. The wound would be roughly around 5 to 7 and even up to 10 centimeter long. So since it's a smaller wound, lesser wound-related risk and complication, as well as shorter hospital stay. This implant was first reported in the year 2022 by Frontiers in Surgery. That's the first few cases that is being reported of usage of such an implant. Second case is something slightly more challenging and more difficult. In a sense, it's a 60-year-old lady who twisted her right ankle while coming down the stairs, the same way after the injury, patient unable to weight bear. So as you can see here, this is the this is the articular cartilage. This is the articular surface of the patient. And this is another one that has been opened up. On top of that, this articular fragment supposed to be down here, it has been pushed up there. So on top of this fracture, patient has a fracture over this area, the medial malleolus, and the lateral malleolus, as you can see right here. And the lateral view you can see is a long fracture along this line. So this patient had what we so call the trimalleolar fracture because it involved the 3 malleolus of the ankle. So this patient had to undergo surgery to get back the congruency and also the status of the ankle. Patient had to undergo a surgery for plating and a plating of lateral and posterior malleolus as well as screw fix of medial malleolus. As you can see on the X-ray here, this is the initial articular cartilage. This is the fragment that has been brought downward, and this is the fragment that has opened up and now has been closed back in and being buttressed on with the plate at the back here. So the articular congruency and also the ankle multi-stability, they are the most vital they are the most vital factors for affecting the long-term outcome and also the lower the risk of arthritis. So this case is slightly different. Although the sprain happened at the ankle joint, but the fracture happened somewhere else. So for instance, this is a 65-year-old lady. She twisted her left ankle, but after the injury, patient was able to walk. So went for normal clinic, get some pain medication, but the pain did not go away. 6 weeks later, the pain still persistent. Patient came to us due to the pain. As we can see here, there's a gapping over here, and the fragment is right over here, and there is no signs of healing on this fracture. Hence, this patient still active. She would require some form of fixation in order for her to walk without any issue later on. So this is the X-ray of post-fixation. The patient underwent a screw fixation for what we so-called non-union of the pseudo-Jones fracture. This is the X-ray that's 2 months post-operatively. We can see the fracture is well united. patient was ambulating well to her pre-injury status. As you can see, there's no fracture line, as we can see in this area. This case number 4 is slightly different and slightly, should I say, slightly severe. So this is a 36-year-old cafe manager. He twisted his ankle while walking on uneven pavement, presented with left ankle pain. Initially, this patient went to normal clinic, had an x-ray done, was told there's no fracture, but roughly a week into 1 week into the situation, patient still having the pain exactly at the ankle. So patient came to us, and this is the MRI of the patient. So from here, this is the axial view. We can see there is a split, a cut over here all around at this piece of bone, and this is what we so-called the talus. Okay, and on the sagittal view, we can see the fracture is a complete fracture. It's through and through. But thankfully, the fracture was undisplaced. Patient was able to be managed in the conservative manner without any surgery. Subsequently, patient was able to off the cast and started walking and got back to his occupation. So above are the slightly special cases. All those are fracture types. So now let's move on to the ligaments kind of injury. So for example, this is a 35-year-old bank manager who is an active marathon runner, had multiple episodes of ankle sprain. Initially, she did not seek any medical attention. However, she started having the right ankle instability and the lateral ankle pain. Hence, she came to us. And from the MRI here, you can see there is a small fragment piece of bone over here. So as you can see on the axial view, we can see a small fragment that happened at around the ankle joint and at the area of what we so-called where the ATFL ligament is presented. On the axial view, we can see it as well on the side here. So on the arthroscopically, on that fragment, you can see the small free fragment of the bone that is running around the ankle that have been removed. And over here, you can see this was pre-reconstructed ankle. There was quite a lot of movement in there. And after reconstructed, the movement, the ankle has become more and more stable. This is the last case I will present. This is the 33-year-old law enforcement agent. He twisted his right ankle during a law enforcement operation in year 2020, sought medical attention to us, advised for surgical intervention. However, patient refused and defaulted any of the follow-up. However, he came back in 2024 due to worsening of the right ankle pain and instability. So this is the MRI of the ankle. You can see up here there was some defect there and a little bit of defect on the other side. This is the MRI of this ankle in 2004. Look at the defect has become way and way bigger compared to the one that's in 2020. And on the coronal view, you can see the osteochondral defect that has gone into the talus is so big, it's way bigger. So in year 2020, the osteochondral lesion or osteochondral defect was measured roughly around 0.6 by 0.6 centimeters. But when it's in the year 2024, the lesion or the defect has increased in size to 1.2 centimeter times 1 centimeter. So in the end, that patient requires some sort of surgical intervention. He was scheduled for surgery. So in conclusion, non-ankle sprain can be treated conservatively without any impact in the long-term outcomes with a proper rehabilitation. And it's imperatively to rule out any structural injury and its severity. And ankle sprain has 30% risk of going into chronic ankle instability and pain. Lastly, a large osteochondral defect or lesion requires surgical repair or resurfacing to avoid further damage to the ankle joint and eventual ankle arthritis. Thank you.
Thank you so much, Dr. Tan Han Ling, for your presentations. I think so far we don't have any Q&A. Just quick questions. I mean, usually it happens commonly when you are going for like sporting activities, right? And then they always say, "Oh, make sure that you warm up before you do your exercises." How important is warming up before you start any of your exercises? Does it actually prevent the incidence of ankle sprain?
Okay, so Prof, this is a good question. So the warming up, it depends on which which type of warming up. So if you say warm up for the Achilles tendon as well as the tibialis anterior tendon, those are important to prevent the so-called the tendinitis. But in terms of the ankle joint, actually there are some say it's better not to stretch the ligament too much because we all know ligament will undergo what we so call the creep as well as stress relaxation. So in any of excessive stretching, it could lead to the ligament to be slightly lax compared to its natural form. But despite of that, the normal warm up will be simple. The lounges, as simple lounges and stretching of the gastroc will be advised, as well as the stretching of the knee will be advised. Yes, Prof.
Okay, I think there's one quick questions from Prof. Tengku Sara. So, what kind of surgery could you do for the last case? The last case that you presented just now.
Okay. Thanks for the question, Prof. So the last case had to the surgery that has been planned for the patient is, as mentioned, the arthroscopy, ATFL reconstruction, as well as the cartilage resurfacing, as well as AMIC, the autologous matrix-induced chondrogenesis.
Okay, I think maybe one last question before we end. Sometimes we see patients with ankle sprain in the clinic, and then we always say, "Oh, make sure you go for your physio rehabilitations." And then most of them, as you know, they wouldn't go. Will that actually, will impair their long-term prognosis?
Yes, definitely, Prof.
Hmm.
This will definitely affect their prognosis and their stability later on. So right after the ankle sprain, first, like I mentioned, is the police of the protected optimal loading. Subsequently, patient will require the rehabilitation as well as a physiotherapy to train up the proprioception and also the balancing of the ankle. If later on patients start having the what we so called the chronic instability, the patient would definitely require a further investigation and further scan to see what all structure has been injured.
Agree. I think one last questions before the end from Prof. Sharif. Thank you so much for your presentations. What is your opinion on managing lesser grade of taladome chondral injury?
So depends on the size of the defect. So if a taladome defect of the osteochondral injury or osteochondral lesion, some it has been reported that at this current point, there's no specific protocol of mentioning how big is the lesion that requires a surgical intervention. But there were the papers that was publishing that the defects, a small defect of less or smaller than 5 millimeters, a conservative management would be beneficial, and it can treat the what we so call the osteochondral lesion. It will disappear on its own. But there are also reports of any osteochondral injury or lesion, sometimes as small as around 10 millimeters, roughly around 50 to 60% will progress, become bigger, like the last case or case number 6 that I presented. So it's first, it have to depends on the level and also the type of the defect, whether it is confined to the subchondral plate or beyond subchondral plate, and also whether it is what we so call at the location, whether it's at the shoulder end or in the center, as well as if there's any alignment issue or alignment instability of the ankle.
Thank you. Sorry, I missed this one question actually. Just been answered by Dr. Amber. Can we protect the knee? We can protect the knee with a special kneecap support. Do we have a similar protection to the ankle? I think
Yes.
we are looking at those, the bracing and ankle brace and something.
Yes, there is. There are quite a few ankle braces in the market. They are always first. They are from the most restricted to less restricted will be the most restricted will be the cast or the POP that we use daily. Then subsequently we have the air cast or the air cam walker, so called. that can be covered with Velcro. Then as we move along to be more active and as well as less support will be the ankle stirrup. And then lastly is the ankle brace, the normal ankle brace, bracing support that, for example, the one that has the strap and that can protect or hold on to the ATFL region. Yes, Prof. There's definitely the brace for the ankle.
Okay, I think that's about it. I think thank you so much. I think the message here is clear. I think if you have an ankle sprain, don't take it lightly. If you have injuries, please make sure you seek proper medical treatments and consultations by the foot and ankle surgeons. Sometimes it's necessary to get the opinions from them. Yeah. Okay, thank you so much everyone for participating in our UMHealth breakfast session this morning. Thank you, Dr. Tan Han Ling, for the presentation, and hopefully everyone has a good day.
Thank you, Prof. Thanks
Thank
for the
you.
organizer. Thanks.